This episode is brought to you by my Fertility Awareness Mastery online self-study program. Learn fertility awareness from the comfort of your own home at your own pace for a fraction of the cost. Head over to fertilityfriday.com/mastery for details. That's fertilityfriday.com/mastery. This is the Fertility Friday podcast, episode number 255. Welcome to the Fertility Friday podcast, your source for information about the fertility awareness method and all things fertility. I'm your host, Lisa Hendrickson-Jack. I'm the author of The Fifth Vital Sign and the Fertility Awareness Mastery Charting Journal. I'm a certified fertility awareness educator and holistic reproductive health practitioner with nearly 20 years of experience teaching women to connect to their fifth vital sign through menstrual cycle charting, balancing hormonal health, and optimizing the menstrual cycle without hormones. I'm outspoken about hormonal birth control and its impact on fertility and overall health because you have the right to know how your body works and how artificial hormones disrupt that natural process. I host live coaching programs to help you achieve optimal fertility and health because it's important to have healthy menstrual cycles regardless of whether or not you want to have babies. I'm also a wife and mother of 2 beautiful boys. I know, I'm a busy girl, but I managed to fit it all in. This podcast is designed to empower you to take full control of your cycles, your fertility, and your overall health. And I'm so excited that you're here with us today. I'm excited to share today's episode with you. In today's episode, I had an amazing opportunity to interview Dr. Nathan Riley, who is an OB. And for those of you who've been listening to the podcast for a while, you'll know that whenever I have the opportunity to interview a medical doctor, I really take the opportunity to gain some additional insight into what is med school like, what is your doctor's perspective, how is your doctor looking at things, and also what tools does your doctor have in their tool belt. And for many women who have discovered fertility awareness and have embarked upon just advocating for yourself, charting, and approaching your hormones and your cycle in a way that is really different from traditional Western medicine, we often find ourselves at odds with our doctors. Many women will say, okay, I showed my doctor my charts and she wasn't interested. She didn't even want to look at them. Or I really wanted to find out what was going on with my hormones, and my doctor just told me just to go on the pill and that would fix everything. And so interviews like this one really help us to gain some additional insight into why doctors do the things that they do, why they have the perspectives that they do, and how doctors can best help us, and also how we can best advocate for ourselves with our doctors. So without further ado, let's jump into today's episode with Dr. Nathan Riley. So I'm really excited to be here today with Dr. Nathan Riley. Dr. Riley is a physician specializing in obstetrics and palliative medicine. He practices midwifery, minimal intervention style obstetrics with an emphasis on supporting the physiology of pregnancy and birth, as well as female intuition, while empowering women to embrace birth rather than fear it. That is a mouthful. He was born in Pittsburgh, trained in Philadelphia and Los Angeles, and he's currently practicing in San Diego. And I'm going to say that name wrong. Can you say it for me? Encinitas?
Encinitas, yeah. Okay. So, right. We'll make a little correction there. I was practicing there, and then I just about a week ago moved to Louisville, Kentucky. So now I'm in the same time zone as you.
So that would have been like the next part of the bio was like moving soon to Louisville. So update, newsflash, moved past tense to Louisville. He's also a climber, somewhat obsessed with eco-conservatism. His wife is pregnant in her
She's now in the second trimester.
See, I'm modifying the bio. And yeah, so that's part of what we're going to be talking about today, because what you wrote in your bio was my advice on getting pregnant wasn't useful. So I had to seek other things. And being an OB, not just a doctor, but a doctor specializing in women's reproductive function, that was a really interesting moment for you. So I'm really excited for our conversation today, and for the listeners as well I always say, and it's kind of a joke, but it's really not, I love it when I have an opportunity to speak to doctors to really gain some insight into what it is that, how medicine operates, how doctors are trained, so that we can get on the same side, because we all need doctors. And we need to be able to work with our doctors in order to achieve the health goals that we want. So welcome to the show.
Thank you. That was a very nice introduction. You got it all.
Yeah, even with the modifying the bio on the fly, which was fun. I'm really curious because I don't think I've ever met a male midwife. So I would love to hear just a little bit about what brought you into not only medicine, but also focusing specifically on women's issues.
Well, that's a good question. And I always say that I think the original reason was when you're in med school, you kind of go through this rapid fire of here's every body system one at a time. And I wasn't really happy with surgery. They were all kind of grumpy and they had long hours and all their kids had nannies. And then the internal medicine docs and the family medicine docs or pediatricians were overworked and they were inundated with people dumping things on them. And then all the other little organ systems didn't really have enough of like the full body. And what I wanted to do was help people with lifestyle modification and help them eat better and move better and this and that. And it turned out that when I was at OBGYN in that rotation, I didn't hate my life as much as I did in some of those other rotations. And it was really, really nice to be taking care of healthy people that were also really dedicated to keeping their babies healthy and themselves healthy. And so it kind of just fell into that. But then I found out in residency that you don't really have much time to spend with patients, not as much time as I wanted to. And I've had to kind of carve my path from there, which is how I ended up in palliative medicine, which gives me the opportunity to really get to know people on a very deep level. And then I say I say that I practice midwifery because the way that most of my colleagues practice is probably not in line with how I view the process. And I think that the midwifery approach is very much like this is something that we can do and our bodies can do, and we need to get back to that sort of intuitive pattern of thinking about these things. And that's kind of how I've been thinking about it since day one. And so, yeah, the way I practice OBGYN is very much, I think, very, very different from how you would expect it to be practiced.
Mm-hmm. Well, and we met in an interesting way because you reached out to me after reading the fifth vital sign. And for me, it was a very interesting conversation, given that I am not a doctor. And when you shared your experience just of when you and your wife were trying to conceive and it wasn't happening, and you had that moment of realizing like, wow, I learned a ton of stuff, obviously, in medical school, but I didn't learn exactly what to do in this situation. Can you share with us just a little bit about that experience and what that would have, like, what was that like for you?
When you're training in OBGYN, it's a lot of, well, actually any doctor, you're sort of taught to solve problems, right? And so, of course, we then see pregnancy and labor as a problem that needs to be fixed, which is why we step in and we try to help. And while the intentions are good, to hell with those intentions if it's actually causing more problems than good. And so the same goes for infertility, where we didn't. And so I actually, before I talk about infertility, when you talk about labor, we talk a lot about what could go wrong as opposed to actually just embracing what normal physiologic labor might look like. And that's, generally speaking, why OBGYNs, I think, are led astray. And they come in with all these amazing intentions, and then they are taught to treat this like a disease. And so as opposed to understanding what's normal and what the normal physiology might look like in labor, as such, or in the same way, we kind of look at infertility as there's a problem, let's provide an answer. And those answers are usually going to be injectables, they're going to be different hormones, it's going to be a lot of kind of rerouting the menstrual cycle in order to get the result that we want, which is to conceive and to have a baby. And in my training, I did learn a lot about that. I learned a lot about how the cycle can be manipulated with medications, and we do get a lot of good results if our result is a baby in the uterus that comes out at 37 to 40 weeks. But if that's our only outcome, then sure, we have these tools. But if you bring a hammer to every single situation, everything looks like a nail, as the old sort of saying goes. And what I found when my wife and I were trying to conceive was, gosh, you don't just accidentally insert part A into part B and a baby happens to be made, which is, interestingly, my wife and I have talked about this a lot, where she, after the first couple of cycles, we didn't get pregnant and we were sort of frustrated. And I was especially frustrated because, I thought that babies were supposed to be I thought it was just supposed to be easy stuff, and of course you hear the story where couples try to time intercourse and they try to use this 28-day cycle and count backwards and this and that. And that's kind of all that I really knew. And I knew why that system should work, but I didn't know how to troubleshoot it. And the most glaringly obvious point there is that not everybody has a 28-day cycle. And even if they do, it's almost impossible to predict exactly when the ovulation is going to occur. And so I started talking to my wife about this, and I was like, I'm reading this book, this author, she sent me her book and I was reading it, and it's like teaching me all these things I didn't know. And I was talking to her about cervical mucus and whatnot. She was like, "Oh yeah, I've noticed that. I've seen that my whole life." And she's Mexican, so she and her family talk probably a lot more about GYN related issues. I don't even want to say issues. You know what I mean? Like the normal physiology of what happens with the vagina, with the vulva. And so she's a lot more open to talking about it with her family. But yeah, she had always noticed there's a different consistency in this and that. And so suffice it to say that she understood that I was getting frustrated with not being an expert and not having the answer to this problem, which we as doctors are expected to have. And when we don't, we're considered incompetent, right? We're considered failures, or where did you go to training and this and that. So I admitted to her, like, I just don't know if I have the answers, but I'm reading this book and there's all this good stuff. And she finally was like, why don't you just let me try this? And within like a cycle or two, pow, we were pregnant. And she wasn't following necessarily your book, but it was something that she kind of intuitively sort of knew already. And so the book, it was probably more educational for me. She kind of already sort of knew this. But anyways, yeah, within a cycle or two, pow, we were pregnant. And maybe it was coincidental, but I do think that she kind of had an understanding of this just naturally from what she had talked about with her female friends and her family members. And of course it worked. And so it was a lesson for me, like, oh, you really don't have all the tools. And if residency wasn't good training enough in learning how arrogance and maybe thinking you have all the answers doesn't really get you some places, especially with the pregnancy and labor and delivery process, this was another just reawakening of like, gosh, like we are really missing the mark in how we're training physicians to maybe talk about and to even practice women's health.
Well, so I can just imagine what's happening in the listeners' minds right now, because a lot of my listeners have doctors and they have gone to their doctors with questions about their cycles. And within this short period of time, what you're saying and the way that you're looking at it, even the way that you described your understanding of birth, is very different to most women's experience with their OBs and with their doctors.
Yeah.
So can you tell us a little bit, you've kind of talked a little bit about your training, but why are you different? Like what experiences happened for you to either shift your perspective, or did you already go in with that perspective that birth is like a normal physiological event? It's not necessarily a problem, but problems can arise, versus birth as a problem that those types of, these are different philosophical outlooks on birth. So did you come in with that perspective, or did you learn it somewhere along the way? And why are you different to most OBs?
Ever since we talked the last time, I actually have been thinking about it because I don't have a really good answer. And I don't think I'm necessarily a better OBGYN. I think that, and not that you're implying that, but when I'm thinking about it, it's like, well, what do I do differently? And what I do differently is I'm patient and I get to know a person and their story before we try to modify anything. Because not only is physiology important here, but maybe there's been some trauma in the past, or maybe there is some social history here that's making it very, very hard. Like, in your book, you mentioned in the fifth vital sign, the stress component affects all of our physiology in sometimes very detrimental ways. So if a person has some other stressors in their life, it impacts that. So I was oftentimes sort of not scolded, but it was sort of frowned upon that you would spend so much time talking to patients and getting to know them. It's sort of like, why is this relevant? Well, it's all relevant because a person's story dictates how their bodies work. And then more specifically, though, one thing that I learned very early, and this is like first day in OBGYN training, you're really not there to get into how they got named and what their mom and dad's relationship was like, and do they have pets at home? What sort of things are at home that are not in this hospital, and how can we create that? There was in my intern year, there was an attending physician, which is the word we use for a supervising physician of residence, who, in contrast to all of my other attendings, would walk into a labor room, not only very quietly, but very cautiously, almost asking for permission to be there. And even whenever like everybody else is redlining it to like danger, 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 he would sit there and just sit with the patient. And instead of making them fearful about what's happening or making them worried, maybe unnecessarily about that 1 in 1,000 thing happening, he turned his brain on and just started thinking like, what are we really looking at here? Should I be really concerned? And until he came to a conclusion that like, this is a really serious situation, he would never just jump into action. His name was Emiliano Chavira, and he ended up leaving that program and going to another hospital. But having seen how he behaves, and he was also an MFM, which is one of the high-risk OB docs, and watching him sort of behave in that way when other people started sounding the alarms, I thought was not only good medicine, but it was just being a good human. And so I sort of modeled myself after him and some other individuals that had a similar style. And I found that not only did it lead to better outcomes, but it also made more sense, both scientifically and physiologically, and it actually supported the evidence. And so I guess what I'm getting at is that the only real difference is that instead of following a protocol in my head that's based around that 1 in a million, those times where we could become anxious and could become scared are opportunities to use these big brains of ours, to try to make things right for this patient's experience and to not make them afraid, and to remember that physiologically this is a normal thing that should be normal. So is our technology limited? And the answer is yes. Our brains really are not limited though, and we have the ability to do quite a diverse array of things that can make people feel safer and can actually lead to lower C-section rates and to better outcomes, into more, quote, natural ways of doing what the body's already prepared to do. We just have to support that physiology as opposed to contradicting it and trying to force it to change course. And so he became a mentor to me, and I don't even know if he knows that, but he may be listening and he may hear that, but I think that really did kind of set the tone for me very early on. And even things like as complicated as breech, which is a very controversial topic now, he will accept a woman's desire to have a breech delivery if she rolls in and she's laboring and there's a butt hanging out there. And I've seen quite the opposite with other attendings who would basically say, "We got to rush you to the OR," and like there's a butt sliding out. It's like, well, what are we really worried about here? Like what are the real things that we should be afraid of? Is this one of those situations where we're worried about the baby not coming out vaginally with butt first? Probably not. And so I watched him do that methodically, and it was really empowering for me as a physician to realize like the art of doing nothing really does play out. And so I think that applying that philosophy to everything from fertility to just basic surgical practices and everything else really goes a long way.
Mm-hmm. That's really helpful. I feel like that. And it's probably also challenging for some women to hear, because then they're like, well, I live in, I don't know, the Arctic, and he's not going to be my doctor. So how do I find another? So to give us a sense of, because part of the reason why I was really looking forward to this conversation as well is because we need to have a conversation. Like everyone has to put down their pitchforks. Mm-hmm. Like we have to be able to have conversations and understand where our doctors are coming from. No one goes to med school because they want to destroy anyone's life. You're going to med school because you want to help people. You want to, encourage them to be healthy. You want to save lives, like whatever the case is. And so I feel like it's really helpful, especially for women who are discovering fertility awareness, learning to chart their cycles. It's often in direct opposition from what they're being told by a lot of their doctors. And many women have had a lot of challenging experiences with their doctors, feeling that they're not understood and things of that nature. One of the things that you said to me in one of our conversations before today that really struck me was that so I'm paraphrasing, so correct me if I'm not getting it right, but as a physician, I mean, culturally, you're expected to know everything and to have all the answers and to be a specialist in every single area. And so I can't even imagine what patients come to doctors with, like, right? Like everything supposed to be and I feel like there's probably more than two ways to respond, but for simplicity's sake, there's like two ways to respond. One, you can like become really arrogant and act like you know everything. Or two, you can acknowledge actually that there you didn't get trained in every specific area. Did you want to speak to that a little bit and to kind of help some of our listeners understand why they may have had such a different experience with their doctors?
That's a really good point. I do remember us talking about that. I want to, before answering that, I think it's important also to I think reconcile this sort of new feeling that where I realize that doctors aren't even necessarily needed at every single birth, right? Which in people that have had, and I don't even mean doctors, I mean midwives, et cetera. There's a lot of people that want to do this completely free of physicians and midwives, and oftentimes that actually works out okay. It's our role to sort of identify when is it that maybe some help from a surgeon, because my training is 70% surgical. So when do you need my help or the help of the nurse and midwife and everybody else? When do we actually need to get involved? And I think that in order to develop that, it's important to not be steeped in a culture of always having all the answers. Because like I said before, if you're a surgeon, then surgery is going to be the answer anytime a problem presents itself. And so I think that the reason that people have run into some dilemmas in discussing these things with their doctors, I think it's complicated, and I think but I also think that it's that we're maybe coming out of this place where women and patients in general do not feel like they have any sort of place in bringing up their concerns or objecting maybe to these various options. And nowadays, within the information age, people do have information and they are sharing stories. And I do think physicians are slowly coming around to this idea that we can't just go in with a hammer and expect to solve the problem. So I think that the first real problem we have is that as physicians in training, we're taught that if you don't have the answer or if you make a mistake, then shame on you. And so what you end up with is a culture of people who, like you said, they go in with hours and hours of volunteering. And you read these personal statements from people trying to get into residency or fellowship or whatever. And the personal statements, like a 1-page essay about who you are. And some of these people are like bleeding hearts, want to do everything they can to make our species live longer and to make birth safer and to keep every pregnant woman perfectly healthy. I mean, they come in with all of these great intentions. But then in a culture, and this is the only culture, by the way, across the entire rank of professions, where you're never allowed to admit failure or to admit that you need help with something. Otherwise, you're seen as incompetent or you're seen as maybe just not cut out for this. And I actually experienced that myself. And
sorry, would you also be opening yourself up to liability?
I mean, that's kind of how medical liability, like that's why that became a big issue, is because anytime a doctor says something, if there's one example where, that goes against what they said and you don't have something to back it up, then suddenly you may lose your license. So you've developed this defensive nature of medical practice, which is like anybody who has any doubts in my practice is a threat to my entire livelihood and my family and everything I've worked for 30 some years. When you realize that you're not only that you're sort of you're sort of nourished in this way to become a physician that feels not only the only one with the answers, but unable to admit when you don't have an idea and you want to go look it up, like that's an admission of maybe malpractice. And so your patients that are going in are going to meet a doctor that has been dedicating his whole life to this practice. And when a different tool is brought to the table that maybe they're not quite familiar with yet, it's going to seem like a threat to their existence. And this is not a matter of let's make sure the doctors have a purpose in this world. It's just a matter of making it safe for doctors to admit, like, hey, I haven't learned much about fertility awareness. Please educate me, like tell me more. That once we can get that dialogue going, this is not going to be a problem. These are good people that just have to protect their butts. And they also have their egos that they're very easily bruised because they've been taught to never admit failure. And so I feel like part of my, the reason I even like doing these interviews is to encourage people to ask questions, encourage physicians to sit there and just hear and just create space for these conversations to take place.
Mm-hmm. Well, I just remember even just you describing that, it sounds very stressful. I think anyone can appreciate the stress that it would cause, even to be in a professional situation like that, and to realize, to realize that you don't know anything about a certain thing. And so it's safer to just discredit it than to actually acknowledge that you just don't know about it. And I feel that this is why this conversation is important, because doctors are human beings with emotions and all of the pressures associated with being a doctor, having to come up with all the answers within a very short appointment. It's I think we have to kind of understand that. But at the same time, it does make it difficult for us to then expect the doctor to have all the answers and to be able to fix everything. It's also unrealistic to expect that if you consider what I just said, a short appointment, having a very, basically very little history understanding of what, all the things that happened up until this point, and then being expected to solve all the problems within a very, that's also unrealistic.
Right. Yeah. I remember we were talking about, throughout our 4 years of residency training, we are quite literally dehumanized. And what that means in the surgical world, and actually not even just the surgical world, even the people on the wards, they take very, very short bathroom breaks. They take very short lunch breaks, if any lunch break. I remember times leaving the OR, running to the cafeteria, snarfing something. I don't even know what I was eating, but I got to get something in here because I got low blood sugar and I got to go back for another 5-hour case. So you're telling a person, don't pee or poop, don't drink or eat, always say yes to everything. Don't create any personal boundaries. Forsake your personal relationships, and you can't sleep on top of that. And by the way, if you gain weight or whatever in residency, nobody's going to feel bad for you. They're just still going to treat you like a person who's overweight and unhealthy, and then they're going to criticize you in the headlines about doctors not, don't take advice from a fat doctor about diabetes. Well, I personally agree. But if you expect a person to go for 15 years of their training and their early, attending careers without ever being allowed to take care of themselves, how are they then supposed to go into a 60-minute consult with you and or any of your patients and understand that this is a human being here? They themselves are no longer even treating themselves like human beings. We are completely automated machines that started off with all these great intentions and with all these great relationships. And then in residency, even my program director one time told me, your wife's going to have to accept that she's going to come second. And I went home and told her that. And I was like, babe, prepare for a rough ride because they're not going to like me here. My wife and I have the most incredible relationship, and I would never trade that for anything, let alone a job that doesn't let me even feel or think for myself. So yeah, it's a really, when you walk into a physician's office, there's far more than just a person that you perceive as just doing whatever he thinks or she thinks is right in order to get rich. They're not even getting rich anymore. This is a really, really rough time to be a physician, I will say.
Yeah, that's really, I don't even know what to say. Harsh. Sounds like not even enough. It just made me think of the interview that I did with Dr. Aviva Ram, because she was a midwife for 20 years. Again, don't quote me specifically. It's from what I remember from our interview before she went to med school. And the way that she talked about it, from what I remember from our interview, it sounded like she had to recover from it. The experience was very just hard on her, emotionally, physically, et cetera, because of what you're describing, which is just the work. It's kind of like, I went to university and I took my Bachelor of Arts degree, but it sounds like that on acid times 1,000, right? Because I was able to sleep and you know what I mean?
Yeah.
So I don't know, how does that then, because I think you touched on it, but I feel like I want to hang out here for a little bit, but
sure. How
does that type of experience from your perspective, so having gone through it, if you design med school, what would you do to is it necessary? It must be necessary, right? To get to get all that information in your head? Like, and then how does having that experience then change how doctors are interacting with people? You know, like,
Yeah.
it feels like you go kind of, it's like a bad analogy, but it's like going to war or something. Like you come out kind of traumatized with battle wounds, and then it kind of justifies everything from there forward. Or am I getting this wrong?
No, you're totally right. So you go through this annealing process, which, by the way, is important. It is important that you are able to act, that you train your brain to act very decisively and deliberately at the drop of a hat. And if anybody out there has had an emergency C-section for a good reason, I'm sure that there's a lot out there that are not for good reasons, but let's take a really good reason, whatever that reason may be. You want somebody who's extremely good with their hands and is very decisive so that you don't die on the operating room table. And that goes for surgery, that goes for people that roll into the ED and have some horrible medical condition that you need a hospitalist or an emergency room physician to act very quickly so that your lungs or your heart doesn't shut down. You know, there is a good reason for that. On the other hand, like I said, you can't produce this community of healing, which we all seem to pretend like that's what healthcare is. I know that the terms like these cliche words like sick care and everything, I mean, it's very true. We have a hospital that really only has the capacity to keep people alive, as opposed to really getting into the heart of what really drives health. And, you know, a lot of that is dependent on your personal relationships, how much you're sleeping, what quality of foods are you eating? Are you able to afford to take time to sleep? And instead we just say like, oh, this patient's non-compliant. They failed to show up for clinic. Forget them. Like they must not care about their health, blah, blah, blah. Like that's just not the reality. So, but again, if the loudest voices in the room, which in some cases are physicians, now oftentimes it's business people running hospital systems, but that's a different conversation for a different time. If those people have been trained in this way, you know, how can you expect them to see this whole person? They are not even whole themselves. And I can't tell you how many people, you know, go through divorces and then they're paying alimony and they have to take extra shifts and they become even sicker and even more sort of removed from their social life. To answer your question about how to fix it, I really don't know. And unfortunately, a lot of young people that want to go into medicine, I try to actually not steer them away from medicine, but make sure that they really want to do what it is that we're doing today, because it comes with a huge price. And I, like the woman that you said you interviewed, the doctor, I feel like my year of fellowship in San Diego, where I was practicing palliative medicine, was such a different learning environment in such a way that I was encouraged to ask questions. I was encouraged to admit when I'm wrong, because only then can they actually fix what it is that my learning edge is and try to help push me further. And I got extraordinary training there in 1 year, but never once would they have told me, hey, you got to put your wife second. Like, no, that's BS. Like, it's not going to happen. She has witnessed this struggle for me, and I would not be here without my wife. I'm 100%. And the failure to recognize that is something that just from the very top, needs to trickle down through the ranks of medical education. There's this idea of, within the medical education system, this idea that you kind of have to pay your dues, you know, and so the long hours and the kind of being shuffled around and really not respected it just has to stop. And when I have learners under me, whether they're fellows, residents, or med students, I try to treat them with the utmost respect, because you know what they've been through. And the fact that maybe some physicians that are further removed from that can't see that is just emblematic of how far removed they are from their own humanity.
That's pretty deep.
Heck yeah.
So it occurred to me, you know, that there may be doctors listening who I have not had enough conversations with doctors to even know what they would be thinking. I would imagine some might be thinking, well, you're painting med school with a pretty negative brush. There may be doctors who went through med school and were like, it wasn't that bad. It was okay. It was necessary. It made me the doctor that I am today, and I wouldn't trade it. And I imagine that there's some doctors that you've spoken to that would say, absolutely, you know, it was pretty traumatizing, but we made it through and even that, the fact that what you're describing, even that speaks to how much a person is dedicated to wanting to help people and to be part of this profession, because you could quit. So choosing to go through that and to make it all the way through med school is really an achievement in that respect, not only from that educational aspect, but also like emotionally to actually get through it all. So how do you address that, or what have been your experiences, just because you are a doctor and I'm sure you have lots of friends and colleagues, obviously, who are also doctors? Like, how do they feel about it?
Well, I think that most of my physician friends, I'd say it's probably a split, 50-50. Half would say, don't go into medicine. The other half would say, if you go into medicine, make sure you know what you're getting into. And I probably fall into that latter group. But in med school, to clarify a little bit, I had an awesome time in med school. Residency just broke me down into nothing. And
so we're talking, because see, I'm not a doctor. I didn't do either. So we're talking about the difference between medical school and then the residency training, which is where the real grueling stuff takes place.
Yeah, that's where you become what we call house staff. And that's, there's a book called The House of God, it's all about, the number one medical school in the country, the best hospital. And they're alluding to some fictional hospital system, but it really is a surrogate for any major academic training institution. And throughout the book, it's completely ridiculous, the stories that are told in the book, and it's fictional, but it's exactly what you try to get away with, and how you try to punt work to each other and to other services, and like, let's just survive this thing together. And that was actually about medical school, but it talks a lot about the residents and the fellows and this and that. So when I talk to my friends that are like, get out of it, get out altogether, I hear them. And then there's also those people that fall into my category. But what I find harder to understand is when the physicians that have preceded me and they trained me, for example, they'll say, I don't know what you guys are complaining about. Things were so much worse back then. And that is not an appropriate answer. Like, it is still really, really bad. I am so sorry you went through that horrible stuff, but they've had to use, through cognitive dissonance, they've had to justify the means to the end, which is a career that for many of them, they're not very happy with. But damn it, if you're going to complain about what it was, imagine what I had to go through. It's like
badge of honor.
Yeah, exactly. It's this little badge of honor, and they want you to know. So, I mean, it even kind of rolls over into patient care too, where like it makes like they have a hard time empathizing with patients because the patients don't know how much suffering I've been through. And that doesn't help. It's like a victimization. It's kind of like throwing the ball back and forth, and it doesn't help.
You think that hurts? Mine is way worse.
Exactly.
So don't even talk to me. Exactly. Your life hasn't been that hard.
Exactly. Yeah. And we have friends that do that to us too, right? Where you just want to like, you just want to like let everybody know. And then they're like, well, listen to what happened to me. It's like, I didn't ask what happened to you. Like, I just need somebody to like witness my pain here. And so I don't know how you deal with it. It's just people in medicine, I think, are kind of fall into one of two categories. And some of them are so burned out that it's like, you got to get out of here. You got to go and find something else that's going to nourish your soul better,
I just wanted to pop into today's episode with a quick message from today's sponsor, Audible. Did you know that you can listen to The Fifth Vital Sign for free when you sign up for a 30-day trial with Audible? Head over to fertilityfriday.com/audible for details. That's fertilityfriday.com/audible. Now let's jump back into today's episode. Well, so I can imagine some listeners rolling their eyes and being like, so now you want me to feel sad for doctors. Like, are you kidding me? Like, woe is me. Oh my gosh. Med school was hard. Like, blah, blah, blah. So, so basically, I mean, I'm not saying that, but I just,
of course.
This is what I do, right? So I often kind of, and I've heard people say like, how did you know I was thinking that? It's weird, Lisa. But yeah, like I can also see that side of like our conversation right now of people being like, you know what, I've got like period pain and I've been suffering with it for years. And I've been to doctor. And here you are telling me about, what it was like and how hard it was for you. Like, what about the patients who are going through quote unquote real problems, right?
Yeah.
So I guess, how does this information behind the scenes about what it's like to be a doctor and what the training is like and how grueling it is and how dehumanizing it can be, How does knowing this help us as women, as, patients navigate? And how does it help us interact with our doctors? Or how would you like, you know what I mean? Because this is probably something that you wish some of your patients knew. So how do you feel like it could help us all get along and or interact better within our healthcare system?
Well, for any healthcare professionals that are listening, my ask is that we take better care of ourselves in order to actually serve our patients. Because regardless of this, we signed up for these tribulations. We signed up to...
And paid for.
And paid for quite extensively. I earned the right to pay off that debt. These tribulations, you signed up for them, and while while you did sign up, you still deserve to be treated like a person. But I'm also talking to you as the physician. You deserve to be treated like a person by yourself and by your wife, and you deserve, the freedom to have a relationship and to be a person again. And without that, you're not going to be of service to your patients who do have real problems that are just as bad as yours. We get into this funny pattern, especially as human beings, we get into this pattern of comparing our suffering. It's not functional, and it doesn't help either of us. We just both sink deeper and deeper and deeper, and nobody really gets help. And true empathy is not active listening, which is what they try to teach us. Like, you sit and you nod your head and you whatever. But like, true empathy is allowing that space for a woman to also express how bad this is for her. And so when I hear stories about, it's in 7 seconds, you let them speak before you interrupted them. When I hear these types of statistics, I know that it relates back to you needing somebody just to hug you, and for you to just have a freaking sabbatical for a year and to figure your shit out. Can I say shit?
It's okay. I've got an editor.
Okay, shoot. You have to figure all that stuff out, and you need to do what's right in order for you to actually function as a physician. For the patients, and for any woman out there who's had a bad experience with a physician, first and foremost, on behalf of everybody, I'm sorry, and I hope that we are gradually getting better. I think that the global consciousness around the need to let women have the stage and to be simply supported by a room of men, and to be allowed to be heard, and to be allowed to just be treated like an adult that's a human being that has a problem that you may not even necessarily be able to fix. I think that consciousness is rising, and I think that we're getting there, albeit very, very gradually. And I think that my advice for the women that are listening to your podcast, and my advice for anybody who's ever going to have pelvic pain or pregnancy or anything in the future, is to always remember that if the one thing you can control is to simply understand that this is another human being across the way from you who's just trying to help you out in the only way that they know, it might allow for some very functional work to grow with time. And maybe even dropping some of these little anecdotes into conversation, say, I know you guys are overworked, and I know that blah, 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 blah. If you want to throw those in, that's a charming way of just letting somebody know, I'm there, I'm here, we're both people. I know we both have our problems. If you can help me with this, that'd be really, really great. And to just remember that they've probably had, for every one of you, there's 9 other people that have stormed out or written a bad note about them to the customer service rep that calls them from the hospital, or left them a bad Yelp review or whatever. And I don't think every doctor's great, just like every car mechanic's not great or whatever. But there's a lot of really, really good people that have signed up to help you. And if either of us goes in defensively into that interaction, as hard as it might be for you because of bad interactions in the past, as soon as one of us is defensive in that room, I think it erodes the relationship and the ability for us to kind of move forward together.
Mm-hmm. Yeah, I think that's really, really very helpful. With one of the things that we were talking about actually in our pre-chat was, so for women, for example, who have discovered the podcast and they're kind of learning all about their cycles and how it's connected to health, things that they just didn't learn before, because this isn't something that's commonly taught. often at the very beginning of your charting journey, you'll get so excited, you'll start charting and you bring your charts to your OB and you kind of expect them to be right there with you like a happy girlfriend, like, oh my gosh, this is so cool. Whoa, cervical mucus, that's amazing. But meanwhile, they're like, why are you doing this? I don't want to see that. That doesn't help me. So, and one of the things that I encourage my clients to do is really to try to understand where your practitioners are coming from, to start to have an understanding that different practitioners offer different services. Like your OB, unless they took a specific interest independently of their training in charting and actually took a program to teach them how to chart, the chart is basically useless to them because they don't know how to use. It's kind of like if a client brings me an EKG, it's like, dude, I didn't go to med school, so you can have that EKG, but you're going to have to like talk to, like, it doesn't mean that I don't think it's cool. It just means that I have no idea how to read it. So I'm not sure if you want to speak to that, but I feel like as a physician, based on our conversations, there would be some degree of patients coming to you with expectations outside of what you're capable of doing for them.
Yeah. And, you know, as I mentioned at the very, very beginning of our conversation, I went in thinking I was going to teach people about nutrition and about movement and all these other things. And then when you go through when you actually train to be a physician, there is so much material you have to understand and know just on your biochemistry and your physiology and the pathology of when things go wrong, that for me to also pretend that I'm an expert in human nutrition and human movement and the circadian cycles and how potentially different foods or different chemicals used in foods are going to disrupt your thyroid physiology and all that. Like, those are all things that I know a little bit about. But if you want to go to an OBGYN and talk to them about something that they haven't trained to do, or any other doctor for that matter, you're just kind of barking up the wrong tree. And I'm not defending people that kind of shut the door on conversations about fertility awareness, but knowing that maybe we're on the path of maybe understanding a little bit more and absorbing more of this into OBGYN practice, knowing that OBGYNs have a certain thing that they do, you really shouldn't expect them to know what to recommend in the gym or what to recommend to eat. And you certainly can't necessarily expect them to be able to read the chart as well as other people that have actually spent hours and hours and hours reviewing them like you have. I am trying to get there so that I can actually help. And I will be taking your class at some point when I get settled with my 3 new jobs. But I don't find it like it's not a threat to my practice that there's somebody else that knows something. Like, you're never going to be an OBGYN and I am never going to be good at fertility awareness chart tracking as you are. And that should be okay with us. But I guess it kind of goes back to that you need to know everything sort of thing. And, you know, there's a little bit of humility that needs to come with it, that if a woman comes to you with a complaint, number one, you don't gaslight them and tell them it's not a real thing. And number two, if they've been working with another expert, like, why not? Like, what do you have to lose by just opening the conversation with, tell me more about this? And seeing if is it something that might even benefit your practice if you understood it. You may learn more from your patient than they learn from you. And then once you realize that there's that possible interaction that can take place, that growth, you guys can go places together and you can maybe not only help her solve her problem, but you may be able to refer her out to somebody that can. And I wish, Lisa, that this was like super common sense, but culturally in medicine, it's not really common sense. And so hopefully this conversation will help people on both sides of the aisle, patients and their physicians or other healthcare providers, kind of come to terms with us becoming so specialized as a society that, like, I'm going to have things that I feel comfortable being an expert in. And for everything else, I have to kind of refer out. That should be something we're competent in doing.
Mm-hmm. I can agree more.
Yeah.
There's something I want to go back to that you said a long time ago. And you said, I'm a surgeon. And you said 70% of my training was surgical. So once upon a time, I didn't know that OBs were surgeons. I knew they delivered babies. So I kind of I'm talking about like my younger self, but I had no idea. And then I discovered that they were surgeons and I was like, oh my God.
Yeah.
Surgeons. They're surgeons. They're not just doctors. They can cut you open and do things. That is a totally different situation altogether. That is a highly specialized health professional who is trained for the worst possible scenario.
Right.
And so I just want to talk a little bit about, because we've been talking a lot about doctors and all about this kind of doctor-patient interaction. But ultimately, there are situations where we need doctors and we need to have that highly specialized surgeon who knows all the things that can go wrong so that you can survive birth. There are many women alive today who would not be had it not been for their OB and their terrible bedside manner, but their high level of expertise in that area. So can we speak to kind of tie it back to something else that we were talking about as well, is that, I've worked with women who kind of pride themselves on like, I don't have a doctor, I don't need doctors. I haven't been to a doctor in 10 years or whatever. We don't need, like, it can't be like that. We can't be in this extreme situation. You've had some bad, interactions with doctors. I've had some bad interactions with bus drivers. Does it mean I'm never going to take a bus again? No. So can we could all figure this out, right? Like there's bad. So yeah, anyways, I'm just going to throw that your way. Just.
Yeah. So yeah, when I say 70, that was an amazing metaphor. My wife was the queen of metaphors. I think you're pushing her out of the ranking. Sorry, babe. You're absolutely right. And 70% of our training is in surgery. We learn how to do pelvic reconstructive surgery. We learn how to do, of course, C-sections and hysterectomy.
Pelvic reconstructive surgery?
Yeah.
Sorry, I couldn't let that drop.
So let's say that you are, the classic patient would be like 70 years old and they've had 3 or 4 vaginal deliveries. And, 10 years ago, they started leaking urine and stool and they don't know what's wrong. And you do an exam and there's actually a prolapse, which is a weakening of the structures that support the vagina and all the internal structures, allowing the vagina itself to sort of evert. And you have like a bulge that's coming out of the vagina.
Evert meaning like flip the wrong way?
Mm-hmm. Yeah. And you can Google vaginal prolapse.
I will not be doing that. But thank you. Someone will.
Well, now that we've gone into this, yeah. We'll post a picture up there for you. It can be very uncomfortable. It can lead to all these incontinence issues and it can make intercourse impossible. And yes, older people want to have sex. And then of course, they go through menopause and the area gets dry and it rubs against the underwear and so there's all these things that develop. So there's special surgeons and generally now it's called urogynecology or pelvic reconstructive surgery, where you would evert that, generally remove the uterus. You may have to sort of tuck in sort of tighten up the areas of the bladder and the rectum to prevent little pouches from forming and making it impossible to empty your bladder and rectum. So that was 2 minutes of me telling you about something that an OBGYN has trained to do. Mm-hmm. And that has nothing to do with your fertility. It has nothing to do with your diabetes, all of your primary care, your pregnancy, your birth, etc. But in order to do what I just described, that requires many hours of training. And if you want to specialize in that, it's 3 more years of training. And so we do a lot of surgery. From a gynecologic standpoint, that's all the hysterectomies. It's removal of fibroids. It's treating infertility with surgical means like removing polyps or fibroids or whatever we do. We manage cervical dysplasia, which is like cone biopsies or LEEP procedures. We remove ovaries, remove cysts from ovaries. We do a lot of surgery. And so one thing I was talking to, he's actually a urogynecologist, my friend Ryan Stewart, he's a physician here at Norton. He and I were talking about, when you are trained as a surgeon, then again, every problem becomes, a nail and you're a hammer. But even the way that we have to treat the body is a very dehumanized object, because it's not possible for me to cut into such an, Mary. It might be possible if there's a little window that's 7 inches by 3 inches across, and I have to make my incision there and do all of my exploration through that little pouch with the drapes and everything and all of the identifiers removed, because it's hard for me to cut into a person. And so now that same person just finished surgery and they're walking into labor and delivery and they have every intention to take care of you and the baby, but now they're a hammer and there's a nail. And unless they have the ability to switch that off, which very few physicians I think do, because the really good surgeons are really good at being in that place, you walk into the labor and delivery unit and now you might be at a higher risk of getting surgery because, gosh, that's something I feel really good about. I did 70% of my training in it and 70% of my working hours are spent doing that. So anyways, I mean, I can't remember even how the question began. But
Well, I
yeah.
don't even know if it was much of a question, but no, that really is, it sheds some light because, for example, when you're talking about birth, the vast majority of birth is it's not problematic because
Completely
birth
normal.
in and
Yeah,
of itself, is a natural bodily process.
absolutely.
And the amazing thing, like we can't throw away medicine. We need medicine
Right,
because
right.
we have the ability. Imagine, like, I can't even imagine what it would have been like before the ability to detect things ahead of time. So we can actually, no, it's not infallible, but you can, identify who's at a high risk early on in the pregnancy. But you have like the vast majority of women who don't actually need a doctor who's capable of all of those things
Exactly.
that you just described with the
Exactly.
surgeries and the thing,
Mhm.
because it's just like what you said, the woman comes to the hospital and baby's already halfway out of her vagina.
Right,
So,
right.
what do we need surgeon for there? But it doesn't mean that it kind of is more what you were talking about before, where we each can have our specialization, and we have to acknowledge that in certain situations, different people may be appropriate because of their level of expertise.
Yeah, yeah.
Everything isn't necessarily like so, but how do you? I think we've been talking about that the whole time, but basically how to have those conversations and for everyone to put their pitchforks down and recognize like we're in this together. The OB doesn't have to waste their expertise on all of the run of the mill, low risk
Exactly.
births.
Yeah, yeah. In other parts of the world, midwives do the majority of birth for good reason. They're not trained as surgeons. And so that's another reason why I describe myself as a midwife. I actually don't practice GYN surgery anymore because I wanted to focus my skills and my time being with the birth process. And sometimes that requires me to do absolutely nothing apart from a whole lot of active doing nothing and waiting and reevaluating and getting to know a person and holding a person's hand and rubbing their feet and meeting their significant others and all of that. But I'm extremely happy that if something rolls into the ED, like let's say a ruptured ectopic pregnancy, or if there's a C-section that needs to be done, and I'm a little bit scared that there's going to be an issue with scar tissue or something like that, I'm so happy that I can call in a surgeon to come in and help me if needed. And I haven't had to do that, knock on wood, but it's nice to know that there are people that do focus entirely on doing surgery within the female pelvis. And for us to say we don't need that is just naive. There's a lot of people in our age group that are not experiencing problems that are benefited from an experienced GYN surgeon. And I will tell you that in the United States, it's actually starting to branch now. We're starting to see a divide between OB and GYN because the two are very, very different skill sets. I still have to practice gynecology because there's an overlap of probably about 50%. But it does help to know that if you come, and this isn't me plugging myself, I don't have my own practice yet, but if you were to show up and I was the one delivering your baby, I am not a surgeon coming to the table, into the room. You have an obstetrician coming, which might as well be a midwife that has been trained in a whole bunch of other stuff and knows how surgical practices may affect your pregnancy or some medical issues that you had that I studied in all those years of studying in medical school and residency might affect your pregnancy. So I see myself as like a shepherd in my flock of patients. I just want to get them all to the right pasture. And if I can do that by not having to go over there and push, one of the sheep in the right direction, like let's just let physiology kind of do that for us. That's kind of my approach.
But with that being said, if a woman's listening and you have an OB who is a actual surgeon who's trained in all the things, then they're not holding your hand. They're not rubbing even the midwife doesn't do that. So, right. I mean, I learned that I had a midwife both times I had my children. The midwife is there as a medical professional to deliver the baby. The midwife isn't even there to rub your back and your feet. It's not like a fun call. You know what I mean?
Right.
She's there as a medical. So I think also we have to have that in our heads. And I think hopefully this conversation has helped to pull the curtain back so that we have a better understanding of doctors, the training they go through, and also their perspectives. Because I think that's really, really important. We can't keep going to doctors and expecting them to do every single thing, expect them to give us nutrient protocols and all kinds of alternative therapies when that's not what their training entails.
Yeah.
And and you can't expect your OB to be holding your hand and rubbing your back and stuff, because again, that is not part of the surgical training. That's a really expensive back rub. Like, honestly, those hands, are you kidding me? Right? They're worth millions.
Yeah, totally.
Well, so, I mean, I feel like we've covered a lot of ground today. Based on our conversation, is there anything kind of that you'd like the listener to take most from our conversation?
I think this goes for anybody, not just patient, physician, but we all have to be a little bit more generous with one another, and just try to see, life through another person's narrative. We all have stories. We all have our own things that we've suffered through. We all have our own traumas, and some traumas are worse than others, but we need to stop. We need to stop comparing our suffering, and we need to just give each other a break. And I mean, there's a lot of problems in the world right now, and we kind of just need to be easier on one another. We're all human beings kind of going through this world multiple thousands of miles per hour on a giant rock around a big ball of fire.
You had to take it there.
Yeah, I did,
Well, yeah, no, I think it's really important to humanize doctors, and then, of course, for doctors to humanize patients.
Absolutely. Yeah.
Because it's interesting, because it felt like you were talking both to women and to patients in general, but it felt also that you were talking to doctors. And It's very interesting because I don't remember exactly what we were talking about before we started the chat, but I said something like, it sounds like what you're saying is you want the doctors to kind of like look at their patients and realize that they're human beings and treat them accordingly, right? Like,
is that what I said?
This is an actual person in front of you. We want to actually remember that this is an actual person.
Yeah.
Actually, I think before we end, we can just quickly touch on the medical conservatism, because I think that's what brought up that part of our conversation.
Yeah, sure. Well, I wish I had more to say right now. It's something I kind of discovered recently, but there is a bit of a movement towards medical conservatism, because especially in the US, our healthcare dollars are just racking up exponentially. We're not really seeing that much better outcomes, meaning all these things that we think are helping, from your kidney doctor, your liver doctor, your heart doctor, lungs doctor, whatever, all those individual interventions don't seem to be helping us get better faster or to live longer necessarily in a healthier state. So this medical conservatism movement is some pretty esteemed physicians out there speaking out on like, are we really doing the right thing here? Maybe we should be doing less. Maybe less is more. And maybe we're going to actually see better results if we stop trying to, solve problems, as opposed to getting that big picture view, sort of like what we talked about earlier. But then there's, another handful of physicians that think that this is very nihilistic, and it seems like it's turning its back on the medical system. And I don't see it that way. I think that we do need to start becoming very judicious and prudent stewards of when we do things under the guise of doing it for the patient, and when we're doing things, appropriately. And so I hope we can have another conversation about this later, but it's something that I've discovered is that there's actually a term now for this way of thinking. And I think people like me have kind of fallen into that sort of thought process from the very, very beginning of their medical training. And when you're in a system for so long, I think through, again, cognitive dissonance, you just tell yourself, oh, well, I'm helping. I must be helping. I have to be helping. Otherwise, I wouldn't be here, right? Right, guys, right? And you start, you're not really rewarded for questioning that.
So the basic idea, so that I'm following, is kind of that you are, instead of going through and like you have all of these possible solutions to the problem. So instead of going in and doing intervention after intervention, you literally are just asking yourself the question of, is this what I should be doing? Like, it's not even saying you shouldn't do the intervention, but it's more just asking the question, like, is this what I should be doing? Is this helping?
Exactly. Yeah. And I think a lot of our medical stuff, especially in OBGYN, has become very dogmatic. It's like, well, of course we would do that. And then you actually step back and you say, should we be doing that? And you find that the literature maybe doesn't even support it. And I'm not saying that we're doing a whole bunch of dangerous stuff. What I am saying is that we always, it's not scientific to accept something as being the right answer without asking, why are we doing it? And in what context might this actually be helpful? It's just not scientific to not practice medicine like that. But for multiple reasons, which I won't get into, I think that we tend to fall into the opposite, which is like you just get carried downstream and you do what the other people do. And that's just how it's supposed to be, I guess, you know?
Well, and isn't this like going back, like I, again, didn't go to med school. So the Hippocratic Oath, like that's a thing, right? That you say or whatever. And it's like, first do no harm, right? Like this is, so isn't this kind of like the same thing? Like, because it's controversial, but I'll just say it, you know, because I've had conversations with doctors who identify, say, for instance, with like, how do I say it? I've had a conversation with, you know, doctor, or I'll just say doctors who feel conflicted about, say, for instance, prescribing the birth control pill, because they're very well aware of what the research says are the side effects. And they feel conflicted about prescribing a medication that causes potential harm in the body to a otherwise healthy person that has no issues. So you go from otherwise healthy person with no issues to then prescribing something that is known to cause certain types of issues in the body. So to clarify for everyone who I just pissed off by saying that, I am not saying that I agree with that. And I do believe women should have the right to access any type of medication that they want, provided they have been, you know, informed about it. So just, that's what I'm saying about that. But I'm just saying, like, that whole concept of like, if you took a moment and thought to yourself, could this cause harm? And is this the best thing to do? Literally just that that little conversation with yourself. That's a very interesting, if all doctors did that, and so kind of conscious medicine, just made that up, but seriously, what would, like, that would probably be different in terms of how people practice medicine.
Yeah. I mean, the birth control pill, I think, is a very good example of that. One thing that I was also thinking as you were talking is the idea of like when to go to the hospital when you're in labor.
Yes.
So, you know, you could give a formula. You could say if they're every 10 minutes apart, lasting 1 to 2 minutes, and, you know, you're having a hard time conversing through that, like, sure, that's a good time to go to the hospital. This is literally based on nothing. Like, you know, and when you come into the hospital, I can't guarantee that you're in labor or that a baby's going to come out within an hour or something like that. So to give you an example of what medically conservative approach would be is, well, first of all, what's your goal in going to the hospital? Well, I don't want to have any medication or have any intervention. Okay, then maybe you don't have to go to the hospital. And if you want to come in and be checked out, or if you have any fears, I'm here to like listen to those fears and address those fears. But it would be considered nihilistic of me to say that maybe birth outside of the hospital is okay. Maybe birth in a birth center is okay. And I'm not saying, again, like you said, you have to give the caveat because of the cultural barriers we have, that are you suggesting, Dr. Riley, that people should not be having babies in hospitals? Like, that's not what I said. What I said is
page news.
Right.
Doctor says hospital is useless.
Shame. Yeah.
That's not what happened here.
Right. What I'm saying is that, you know, for a lot of patients that have reasonable fears about being in the hospital because of prior traumas or, you know, in the hospital environment or whatever, maybe investigating a birth center with a midwife might be a really good option. Or maybe, you know, for some people, they're going completely, you know, all natural. They don't even want to have a doctor's input. I think that sometimes is really not the best thing for people. But again, for those people that have a successful experience, they say, well, what now? You know, why was I told that this wasn't safe? Why and this and that? And it's because we're not even allowed to ask the question about the utility of certain interventions. And again, I'm not promoting free birth or not going to a doctor. Not at all would I ever suggest that, because for some patients, that is exactly what you should be doing. And maybe every 2 weeks, because you've got some really high risk things going on. But the problem is not, do we have this intervention or this intervention? The problem is that in this medical culture, it's sometimes seen even within subspecialties as heresy if you're going to question the dogma of doing any of these interventions without saying, hold up, this intervention may not be right for this person in this scenario. Like, we should be doing that with every single intervention, and we're really not, whether it's time constraints or it's reimbursement from Medicare or whatever. And that I see as a really, really big barrier to the practice of medicine the way that you and I both think it could be practiced, maybe ideally.
Mm-hmm.
Does that make sense? There was a lot, I think, packed in there. But
Yeah, it makes sense because ultimately, like to break it down to the simplest form,
yeah,
it's saying we should be able to just simply ask the question of, is this the best thing to do? Is this intervention necessary?
right, right. And
And to not necessarily just with like the dogma, like as if medicine is religion. Like one of my midwives liberated me from the constraints of all of this with one simple question or one simple statement. She was like, you know that you have the option to, accept or decline anything that your doctor recommends, right? I was like,
excuse me? Magic. Yeah.
and with that, my whole brain opened. So there was
Yeah.
there's a whole new groove in there now.
Right. I mean,
Because
we're here to help people. If we're going to do things that are actually causing more problems, then is this the right thing to do? Maybe not.
yeah, but yeah, no. So it's a very interesting point, and I think we'll leave that as food for thought for the listeners today. Well, Dr. Riley, thank you so much for being here.
Hey,
This was
my
so much
pleasure.
fun. I could have just kept talking to you all day, but I
Yeah,
think at some point we're gonna have to like eat some food or something
I think so.
separately because we are
Sounds
not
good.
in the same country right now.
We're not.
But no, thank you so much for being here. This conversation was so necessary, so informative. I know the listeners will really appreciate it. I love that we were able to just gain more insight in terms of doctors and what your stressors are, what issues that you face, and also to really acknowledge and recognize that doctors are trying to help us with the tools that they have available. And it is not useful to anybody to get into this kind of adversarial, I don't need doctors, doctors are all
Sure.
whatever. It's just not useful for any of us to get there. So thank you so much for being part of this conversation.
My pleasure. It's a huge pleasure.
Well, so where can our listeners go to learn more about you and what you do, the listeners who are local, to work with you? And also you have a podcast that I've been on, which was a lot of fun.
Yeah, so I have a website, nathanrileymd.com. And through there, you can also find the podcast, which is called the OBGYN, where I review all of the American College of Obstetricians and Gynecologists ACOG's practice guidelines. And I kind of run my own thread, similar to the topics we've been talking about. I run my own thread of sort of healthy skepticism about certain things. I review the literature for certain interventions that I do think are really helpful, that may be more controversial or otherwise. And so it's my own twist, but it really is meant to be like a 30 to 40 minute summary for anybody working in OBGYN to review what ACOG's been recommending in their new guidelines. And then on social media, it's Beyond the MD, as in MD like medical doctor, Beyond the MD.
Awesome. Well, I will put links to all of those in the show notes page for the listeners on the go. Thank you so much for being here. This was a fantastic conversation, and I'm excited to share it.
Thanks, Lisa.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/285. I hope that you enjoyed my interview with Dr. Riley. It was such a treat to have him on the show, and I really appreciated his perspective, and I really enjoyed the conversation that unfolded. It's so helpful whenever we can gain some insight into the perspective of our healthcare providers. It's so helpful because at the end of the day, we all need doctors. We all need, well, I always say that we need a healthcare team, especially if you're dealing with hormonal issues or, menstrual cycle related issues. And that's because the Western medical paradigm typically does not address the root cause of what's happening with you. And typically what's in your doctor's tool belt are often drugs, surgeries, a variety of different medications to kind of force things to happen, as opposed to things that could, improve and help the underlying factor so that your body could heal and do what it needs to do naturally. And I think it's really important to just understand that paradigm, because it doesn't mean that there's not a place for that. And it doesn't mean that, there aren't times when we need to be going the traditional route, but it's really important to understand what your doctor can do for you and what your doctor cannot do for you, and to be really respectful of your doctor's expertise, education, and where they're coming from. And so what I really appreciated about today's episode was the insight into residency and how grueling it is for doctors. And, it really gives some insight into, I feel like in any interaction you have in the future with your doctor, you can kind of appreciate more why he or she may have the perspective, bedside manner, and whatever have you that they do. But I think it also gives some very important seeds of hope, because when you're in the real world and you're out there trying to find a healthcare professional, like any situation, even outside of medicine, there are going to be some healthcare providers that have better bedside manner than others. There are going to be some that specialize in certain areas more so than others. And there are going to be some that really mesh better with you than others. And I think it's really important to remember there are amazing doctors out there. It may be harder to find depending on where you live. It may take a couple of appointments with doctors who you don't have the greatest experience with. But I think the most important thing to remember is you have the right to excellent medical care. And to put it into perspective, I mean, if you were going into Walmart, or if you're going into whatever store you're going into and the sales representative was super rude to you, you wouldn't just stand there and enjoy that rude attitude or whatever is going on. You would leave and maybe go to a different store or go to a different chain and get your service in the appropriate way elsewhere. And so I think sometimes we forget that if you have a negative experience with a doctor, you don't have to continue going to that doctor. You can find a new doctor. It's not always easy. Obviously, it can be very challenging. It can be very expensive, very time-consuming to find different medical care providers. But you need to know that you have the right to do so, and you don't have to put up with, inappropriate bedside manner or just inadequate care. So hopefully this interview has given you hope, and I'll continue to interview amazing health professionals. I think it's really important, especially if you have had negative experiences with doctors and you're at the point where you kind of feel like, okay, I don't want to go to doctors at all. That's not a good place to be either, because we do need to have doctors on our team. So if you haven't had a really positive experience yet, there are amazing doctors out there, and hopefully this interview has given you hope. And if you have had a negative experience, just want to encourage you to keep going and do some research. I'll link one of my previous episodes where I talk about specific strategies to really find yourself a healthcare provider that is going to support you. And so I would suggest for you to listen to that episode. And also, if you already have your copy of The Fifth Vital Sign, I have a whole chapter on getting the support you need and really specific suggestions as to how to find that doctor that will truly support you. So with that said, I just want to thank you for spending some time with me today. I really appreciate all of you for being part of the Fertility Friday community, and all of you for spreading the word and sharing episodes with your friends. And so if this episode, if you know somebody who could really benefit from hearing it, again, fertilityfriday.com/285. And with that, I hope you have a wonderful weekend, whatever you are doing, whether you're listening to this while going for a walk or working out or whatever you're doing. I just hope you have a wonderful rest of your day. And of course, as always, until next time, be well and happy charting.